In order to understand the imaging of vertebral column, first of all, it is very important for us to understand the normal anatomy of the vertebral column. So we're going to take a look at the structures and the landmarks in a brief way and identify the structures that we need to observe on a normal radiograph, and thus we can move on to abnormal findings on the radiograph as well. Keep in mind that this lecture is focused on the anatomy and how that actually is observed on the radiograph, and we are not talking about looking for conditions or diseases or abnormalities. So in this lecture, we're going to talk about the anatomical features that we can identify in radiographs and imaging in terms of vertebral column, including the vertebral bodies, the joints such as the intervertebral, zygapophyseal and intervertebral joints, and as well as the disc, which are actually a part of the vertebral column, which are present between the two vertebral segments. At the end, we're also going to talk about the investigation of choice whenever we are faced with a decision that which imaging technique we should go for. So starting off, we're going to talk about the vertebral column and a brief overview of the anatomy. There are a total of 33 segments or vertebral segments in the spine or the vertebral column. Talking about the cervical spine, we have 7 segments, C1 to C7. We usually have C1 to C8 in terms of spinal segments, but that does not mean that we have 8 vertebrae in the terms of cervical spine. We only have 7, but we have 8 spinal segments. Now, talking about the thoracic spine, we have 12 segments in the thoracic spine from T1 to T12. And at the end, we have the lumbar spine, which has L1 to L5, which means 5 segments. So a combination of thoracic, which is 12, then cervical, which is 5, so they become cervical, which is 7, so they become 19, and 19 plus 5, which is 5 segments for the lumbar spine, that is 24 in total. So these 24 segments, which is cervical, thoracic, and lumbar spine, these are the mobile part of the vertebral column. And that is why they are separately known as pre-sacral vertebrae as well. Because other than that, we also have 5 sacral and 4 coccygeal vertebrae. These sacral vertebrae and coccygeal vertebrae are actually fused with each other and they are not mobile. And that is why they are differentiated from the cervical, thoracic, and lumbar spine by giving the term pre-sacral vertebra to cervical, thoracic, and lumbar spine. All of these vertebrae have a lot of things in common, but they may have some differences as well. So if we talk about the commonalities in terms of these vertebrae, regardless they are cervical, thoracic, or lumbar, so we can take a look at this picture in which all of these segments or vertebrae have a vertebral body, which is on the anterior aspect. Then we have pedicles on both sides extending posteriorly from the vertebral body. And from these pedicles, we have lateral extensions, which are known as transverse processes. These transverse processes are again joined with each other through the lamina, which joins each other in the center and extends posteriorly to form the spinous process. So every vertebra has 2 transverse processes, one on the left and one on the right, and a spinous process posteriorly. Between the vertebral body, the pedicle, and the lamina is a circular opening or canal, which is known as the vertebral foramen or the central canal. So this vertebral foramen is actually the area where the spinal cord is lodged. Moreover, if you look at the inferior and the superior aspect of every vertebra, so the place where we have the pedicles on both the sides, we have 2 facets inferiorly and 2 articular facets superiorly. A superior articular facets of the inferior vertebra articulate with the inferior articular facets of the superior vertebra to form two zygapophyseal joints. They are also known as facet joints, and thus each vertebra in a mobile segment forms two zygapophyseal or two facet joints inferiorly and two facet joints posteriorly. They also make an intervertebral joint with each other, which is between the two vertebral bodies. These vertebral bodies, in terms of intervertebral joint, are separated from each other via a intervertebral disc, which is a fibrocartilaginous disc. Now, talking about spinal segment is actually a combination of two vertebrae which make a mobile segment. So this mobile segment, for example, here we can see has two vertebrae. These are two vertebral bodies, and they are actually joined together by the intervertebral joint with an intervening intervertebral disc between them. Similarly, if you look posteriorly, the superior articular facets or the superior articular processes of the inferior vertebra articulate with the inferior articular process of the superior vertebra to form two zygapophyseal or facet joints on both sides, as you can see here. Similarly, you can see here as well. The orientation of these facet joints are different in cervical, thoracic, and lumbar regions, which give them actually their characteristic features in terms of their independence of movement. Moreover, you can also see that this is the vertebral canal through which we can see that the spinal cord actually passes, or it is lodged in here. Talking about the joints, as we mentioned, the facet joints or the zygapophyseal joints, as well as the intervertebral joints, there is another type of joint known as the joints of Luschka, which is also known as uncovertebral joints. So these are actually formed by the uncinate processes, and this is actually an uncinate process here. So this uncinate process of the inferior vertebra articulates with the superior vertebra to form a joint of Luschka, or an uncovertebral joint. So now, as we have identified these anatomical features of an individual or of a typical vertebra, now we can also observe them on an X-ray. So let's take an example of a cervical spine X-ray and identify the structures. So first of all, we have the vertebral body, which is located anteriorly. So these here, like where we can see C1, C2, C3, C4, C5, C6, C7, and T1. These numbers are actually mentioned depending on the spinal segment. So these are the vertebral bodies. Then moving on, we have the posterior arch, which is formed by the pedicles and the lamina. So here posteriorly, just behind the facet joints or the articular pillar, and just ahead of the spinous process, we have the lamina, and here we have the pedicles, as you can see. So these are the pedicles, these are the transverse processes, and these are the lamina. Behind the lamina, we have the spinous processes, and ahead of the pedicles, we have the vertebral bodies. So pedicles are actually the posterior bony projections from posterolateral corners of the vertebral body, as we can see here. And lamina curve posterior medially from the pedicles, join in midline at the base of the spinous process, and they form a spinous process. For example, in the case of cervical spine, which is usually a bifid spinous process in a typical cervical vertebra. And then the spinous process projects posteriorly, and they are easily identifiable in this or any other radiograph of a normal cervical spine. Now, transverse processes project laterally from junction of pedicel and lamina, and they are visible here, as you can see here. And they are more clearly visible in terms of AP view. Moreover, there are some structures such as the dents and the anterior arc of C1, and because the anterior arc of C1 is mentioned here because it does not have a vertebral body, because it is an atypical vertebra. Similarly, dents is actually an elongated articular pillar of the C2, which is also an atypical vertebra, which articulates with the anterior arc of the C1, and that is called dents, as you can see here. The superior aspect of the C1 articulates with the occiput in terms of the occipital condyles, as you can see here. C7 is also known as atypical vertebra because it resembles somewhat the thoracic, a typical thoracic vertebra, and that is why it has, because of its resemblance with the thoracic vertebra, it is also sometimes termed as atypical vertebra. Now, talking about the articulations of the spinal segments or the vertebrae in terms of its appearance on a radiograph, as we already mentioned, the articulations include intervertebral disc and the intervertebral joint, zygapophyseal joints, and uncovertebral joints. As you can see here, we have, this is one vertebra and then the another vertebra, and as we can see in the previous picture as well. So these vertebrae, the area between them is actually the intervertebral joint, and this intervertebral joint is actually have intervertebral space, which is actually occupied by the intervertebral disc. Moreover, here we have the zygapophyseal joints, and these zygapophyseal joints are also known as facets joints. As we can see, the superior articulating facets articulate with the inferior articulating facets, and they make these joints here, which are known as facets joints or zygapophyseal joints. Similarly, there we have the uncovertebral joints, which are formed by the uncus, and they are also known as the joints of Luschka. Now, the role of imaging in the assessment of spinal trauma is very important because it is used to diagnose a fracture or a dislocation. It is also used in the assessment of stability and instability. Radiographs and imaging is also important in terms of diagnosis of damage to neurological structures such as spinal nerve roots or spinal cord, or even in terms of impingement of neurological structures such as in cervical radiculopathy, in which there is the impingement of spinal nerve roots. It is also used in follow-up, where it is important because it allows us to visualize and measure our prognosis in terms of the assessment of treatment, that how much improvement has occurred in the patient. For example, if we are treating scoliosis, we can actually use an X-ray to measure the Cobb's angle pre and post treatment and analyze the effect of the treatment and actually the prognosis as well. Moreover, it is also used in terms of follow-up for the diagnosis of long-term complications such as post-traumatic strings or cyst formation. Now, as we already mentioned, that a radiograph can be, or an imaging technique can be very important in terms of your clinical decision making and treatment. So what should be your investigation of choice considering the vertebral column? So if we are suspecting spine trauma, so the first line is actually a radiograph or an X-ray. We can also use a computerized tomography scan to define bony anatomy. And we can also use magnetic resonance imaging if we want to define soft tissue complications, including spinal cord injury, or if we want to observe an impingement on the nerve or the damage to the nerve root. In terms of non-specific neck pain or neck pain, which is biomechanical in nature, something like that, imaging is not indicated in most cases. However, we can still do an X-ray or a radiograph. For example, if we want to observe the cervical spine in terms of its biomechanical features such as cervical lordosis or straightening of the cervical spine. We can also use magnetic resonance imaging or CT scan for radiculopathy or myelopathy. In terms of back pain, imaging is not indicated in most cases if it is non-specific or if it is biomechanical low back pain, but still X-ray or radiograph can be used for the similar reasons as I mentioned for neck pain. Moreover, MRI and CT can also be used for radiculopathy such as sciatica or for myelopathy as well. Imaging is indicated in neck and back pain for chronic, relapsing, and unremitting pain, or in the presence of clinical red flags. We're going to discuss and mention these red flags in the upcoming slides, so stay tuned for that as well. Now, talking about spondylosis and spondylolisthesis, the best is the radiograph because it's cheaper as well and easily accessible, and it is very easily visualized on radiograph, the spondylosis, spondylolisthesis. But if still you want, you can also go for a SPECT CT, which is known as a single photon emission computerized tomography scan. And you can also go for MRI, which is magnetic resonance imaging, if sciatica is the dominant symptom in those patients with spondylosis or spondylolisthesis. In terms of inflammation of the disc, which is actually a soft tissue structure, so discitis, we can go for a magnetic resonance imaging scan. In terms of a tumor such as a vertebral metastasis, we should go for a bone scintigraphy, which is a type of a nuclear medicine technique or nuclear medicine imaging technique. And in terms of acute osteoporotic crush fracture or stress fracture, we should go for a conventional radiograph, or we can also go for MRI when vertebroplasty is contemplated. In terms of scoliosis, radiograph is enough because it's very easy to visualize the abnormal curves and calculate the Cobb's angle on a radiograph, but we can sometimes go for MRI in selected cases as well, depending on case-to-case basis. In terms of sciatica, which is actually the impingement of the sciatic nerve and the radiculating pain and symptoms in the posterior aspect of the leg, we should go for magnetic resonance imaging to visualize the compression of the nerve root or the sciatic nerve, perhaps because of prolapsed disc or something like that. And CT can also be used in cases where MRI is not available. So that was all about the introduction and the anatomical structures of the vertebral body and the vertebral segments in terms of the radiological and imaging. And I hope you learned something new out of it. Keep on watching sqadia.com for more lectures like this. Thank you very much.